Hello and welcome to this next session of the Point of Care Ultrasound course. This is Tom Heller again, and today we will talk about cardiac ultrasound for resource limited setting, the CURLS protocol, which will hopefully become as fashionable to you as the FASH protocol. First, let us look at some data from 2018. The clinicians at Lighthouse is a large HIV and ART clinic, and also taking care, of course, a lot of TB patients. And we looked at which point of care ultrasound applications were most useful to the clinicians. And basically for 100 exams, we consecutively put them in categories why we did them. And as you can see, the most common application is of course FASH. That's the question of is there TB in an HIV patient? And being an HIV TB clinic, this is of course the most common thing. But what you see is that the second most common question was heart. There were heart problems which led the clinicians to say, I would need an ultrasound here to assess the heart. That was followed by liver, kidney, deep vein thrombosis was seen in only few patients, and then gynecological problems. These were the 6 modules which we looked at. So what we can see from this prevalence data, which I just showed you, we can rate the diseases. Some are rare, some are relatively common, and some are very common. And of course, the more common diseases, the more sense it makes to teach the ultrasound skill. But it's not only dependent on the frequency that we see the problem. There are other considerations, and one is the diagnostic impact of ultrasound. Of course, it is nice to diagnose diseases, but if this diagnosis does not change your treatment, then it is probably of less relevance than if you have an immediate treatment change due to your ultrasound findings, or you may even have urgent treatment changes, possibly life-saving, which would be even more important. And then the third consideration when you look at which ultrasound techniques to teach is the difficulty. Of course, if it is easy to teach something, you'll do it easier. If it needs advanced skills and months-long trainings, then probably it is not very suitable for a point of care ultrasound. And if you take all these factors into consideration, you can weight your ultrasound modules. And obviously you don't need the scale to weight your ultrasound machine, but you can see here this weighting. So FASH, for example, it has 3 points for prevalence because in our setting it is very common. It has 3 points for impact because the treatment changes if you start TB treatment can be life-saving, and the difficulty is moderate. I think you can learn it. You can learn it fast, but it is not very easy, but it's also not very difficult. And with this, it ranks the highest. But the second, the heart, has also, it is common, not as common, but still it is relatively common. It has a large impact because it changes your treatment, and the difficulty is also moderate, and that makes it ranking second. And that's why the CURLS protocol is now in this course. What is the CURLS protocol? The CURLS protocol basically is made for patients with cardiac failure and or with radiologically enlarged heart on chest X-ray, like the one you see here. And basically with an ultrasound, we look at this enlarged failing heart and we ask 5 questions. Is there a pericardial effusion present? Because that would point towards pericarditis. Is left ventricular function reduced? Which would point toward congestive heart failure, dilative cardiomyopathy. Is the right ventricle larger than the left ventricle, which would point towards cor pulmonale? Is the left atrium larger than the left ventricle, which can be a sign of rheumatic heart disease and mitral valve stenosis? And is the left ventricle wall, the septum, thicker than 12 millimeters, which would point towards left ventricular hypertrophy? We will go in detail through all these questions in this lecture. But before we do that, one of the beauties of that protocol is that it tries to use only one view of the heart. Commonly, in formal echocardiography, you use transcostal and you use parasternal axis and long axis, and it is quite complicated for the beginner. But this protocol uses basically only the view from the subxiphoid here looking upwards. This is in this video clip here. You can see the position of the probe, which is in the epigastric angle, and it's aimed upwards at the cranially of the patient. And this is the image that is generated. You see in the parts close to the transducer, you see the liver, which is used as an acoustic window, and then there is the right heart, which is the right ventricle and the right atrium, and more distally you see the left ventricle and the left atrium. This is, of course, a very pointed probe. This is a phased array probe. What we use usually is our convex normal abdominal probe. And in most patients we get sufficient images as well. So this clip again this is a normal heart, and again we have the transducer here tilted to look upwards, and it passes through the liver, which serves as an acoustic window, and then we have the triangular shaped right ventricle, the roundish right atrium, and then the egg-shaped left ventricle, and again the roundish left atrium. And then in the back we see this air, the echogenic line, that's the air of the lung adjacent to the heart. So that is the anatomy of the normal heart if from a subxiphoidal view, and that one we need to be sure that we understand first. So let us look at a case. This is a 24-year-old female HIV positive patient with increasing shortness of breath, and this is her chest x-ray, and you obviously, all of you will see that this is a very enlarged heart. This is a cardiomegaly. Cardiomegaly can have multiple reasons, and the best way to get to the bottom of the reasons is to take an ultrasound. This is the ultrasound of that patient, and what can you see? You can see, like we discussed before, you can see a little bit of the liver here. You can see the right ventricle, the right atrium, the left ventricle, and somewhere here is the left atrium. The main thing is that what you additionally see is that there is an anechoic black rim around, mainly around the right heart, but even here towards the tip and around the tip of the heart. That is black anechoic fluid. And that, of course, means that it is a pericardial effusion. And pericardial effusion in our setting is, in an HIV positive patient, is most likely due to TB pericarditis. There are, of course, alternative diagnoses, the same like we discussed about the lymph nodes and we discussed so many times. Sonographic findings are hinting for a diagnosis. They are not confirming the diagnosis, so we have to consider other. For example, Kaposi sarcoma can cause effusions, other malignancy can cause effusions, but the single most common and treatable condition is probably TB. So if you look at this, you can see it is an anechoic surrounding the right, especially the right heart. Let's have a look at another example. This is another patient. You can see again, you have the liver in front with the hepatic veins. You have the right atrium, right ventricle, left atrium, left ventricle, and you see again an anechoic rim around, which in this case pulls around the whole heart, and even here in the back you can see an anechoic rim, a pericardial effusion, which is certainly significant. It's not significant, means in this case it is significantly big enough to be considered as pathology. Don't mix that up with hemodynamically relevant, or hemodynamically compromising. We will come to that later. That is a different thing. Let's have a look at another example just to get your eyes used to it. this is again a patient with a TB pericarditis. You can see the little bit of liver here. You can see the right ventricle, the left ventricle. The atria are not visible, so that's what the problem you often have, that you do not see nicely the four chambers like in an anatomy book. And around you can see this anechoic fluid. And additionally, what you see is that there are fibrin strands and septa in here. It's like material that is covering the heart, and these are of course exudative, show you that this is an exudative character, and this is an inflammatory effusion, very typical. And here's another one, larger still, the effusion, because of course here you can see the right ventricle, left ventricle, and on this heart is like a cap. There are these fibrin masses, strands, which float in the fluid as the heart moves during the cardiac cycle. Yes, so this again a very typical fibrinous exudative TB pericarditis. The next clip shows you basically the same. Again, you see this fibrin strands and fibrin septa here. But what it additionally shows you is, this is a clip that was sent to me via WhatsApp. So it shows you that if you are not sure what you're seeing, or if you want second advice from a colleague, WhatsApp, film the screen, and WhatsApp is quite a good way to get a quick advice from somebody who is more experienced. So let us next look at cardiac tamponade, which is obviously one of the dangerous consequences of a pericardial effusion. And some definitions. First, we need to understand that a true cardiac tamponade is present when there is a pericardial effusion and a circulatory collapse. So how will we see that clinically? Obviously, the patient has inflow congestion, the jugular veins might be dilated, there is low blood pressure, and there is high heart rate because the patient is in shock. So generally, as a sign of shock, you can compare the heart rate, and if the heart rate is higher than the systolic pressure, then you have possibly shock there. Luckily, with the ultrasound, we can diagnose tamponade a little bit earlier, so it would be then an impeding tamponade. This is an effusion plus diastolic collapse of the right heart. So if we want to assess the heart with the pericardial effusion for tamponade, the first thing we would look at is whether there is a high central venous pressure, and that of course the easiest to look at are the hepatic veins. So if the hepatic veins are dilated, then that is the equivalent of the dilated jugular veins. That is very compatible with tamponade. It is very unlikely if the hepatic veins are very tiny and small, then tamponade is very, very unlikely. So that's the first thing we look at. The next you want to look at is the right atrium wall. And you can see that here in this video clip that the right atrium here is moving inwards, changing with the respiratory cycle, and that is a sign of that moving inward is due to the increased pressure on the outside in the pericardium, which kind of compresses the wall inwards. So diastolic right atrium collapse is one sign, and here another patient with a pericardial effusion. See the anechoic area around here. You see here is the left ventricle, here is somewhere the left atrium, here is the right atrium, and you see that the right ventricle is almost invisible. It is very compressed and collapsed. So diastolic right ventricular collapse is another sign of cardiac tamponade. Here is a different example. Again, liver in front, then this anechoic rim, and as you can see here is the left ventricle. Of course, the left ventricle has a much higher pressure, so that one will not collapse. But the right ventricle, the right atrium, they are the low pressure system, and this one collapses intermittently as the patient breathes. So if the patient, during inspiration, there is a better inflow, and at expiration there is less inflow. That's why the size of the ventricle changes. That's basically the Kussmaul phenomenon seen in an ultrasound. So, and now I want to take you through a case from KwaZulu-Natal. This was a 34-year-old HIV positive patient, CD4 count 310, so not that bad. He was seen for increasing shortness of breath and dizziness. Additionally, he reported chest pain for a while, loss of weight, night sweats, but without major productive cough, so he was coughing. He looked very unwell, sweaty, was severely tachypnic, had a low blood pressure and a high heart rate. And on the chest X-ray, a cardiomegaly was found, and this is his ultrasound. You can see the liver again, and as we tilt upwards, we see this large effusion. And again, there is the left ventricle here, and the right ventricle closer to the transducer. And you can see what we just saw on the other example, the this impaired filling that is briefly better during inspiration, but then again during expiration it's worse and it's more compressed. So this is obviously we have clinical signs of tamponade, we have sonographic signs of tamponade, we have a large pericardial effusion, so this is tamponade. So what would we do? As he is severely sick and in shock, we decided that we should do a pericardiocentesis. But of course, often the proper pericardiocentesis sets are not available in African districts hospitals. So what we said, still we need to do something to relieve the pressure, and we decided that we would go with a normal IV cannula, a gray or green cannula, whatever you have at hand. We went through the transcostal, just like we do a pleural aspiration. We did a pericardial aspiration, and that was done, and 400 cc of a clear yellow fluid were drained. The cannula was then withdrawn, and it was not attempted to drain all the remaining fluid. We just wanted to drain a little bit so that there would be enough space in the pericardial sac to allow blood to come in. And the patient clinically improved dramatically in the next 15 minutes. This is a scan which is 15 minutes later. And again, you can see there is the liver in front, and still you can see this anechoic rim. So there is significant pericardial effusion still, but the problem at the right heart has significantly changed. It is much better now. The heart is filling, the heart is slower. These are all signs of hemodynamic improvement. And of course, looking at the underlying pathology, most probably TB treatment, we said we need to immediately start him on TB. Anti-TB treatment, and additionally we decided to give him steroids, at that time 80 milligrams of prednisolone. 2 days later he met me in the corridor and requested to be discharged, and I thought, okay, that's quite quick for how sick he was, but given the fact that he felt well, we said, okay, let us have a look one more time at your heart, and then you might be discharged. So here is 2 days later, and again you can see there is still pericardial effusion, but it has quite diminished, and it is far less. So the problem is much less now, and of course that that is partly due to the TB treatment, but mainly due to in this quick change, it's mainly also due to the steroids that were given. He was then, after 2 months, at that time, it was a while ago, we started him on ART treatment, and the further course was uneventful. Now we need to look at one extra point, that is healing pericarditis. And pericarditis can heal with calcifications, and it can also heal with constrictive pericarditis. And of course, that is a confounding and a differential that we need to look up briefly. First, on the chest X-ray, you sometimes see this even in completely asymptomatic patients. You can see, like here, this calcification in the pericardial area. This is probably a previous pericarditis which healed, either treated or untreated, and which led to a calcification. And we can see that in ultrasound as well. So here is a patient with a constrictive pericarditis, and the main thing that you see is similar to the effusion. You see an hypoechoic rim around the heart in the and lining the pericardial sac. But of course, this is not as anechoic as it is in the fluid. This is semi-organized to organized, and is basically encasing the heart and putting it in a case. So that is something that you need to be aware of, and that is one thing that can be confounded with the effusion. Another example you can see here for the different type of ultrasound machine, again a cardiac probe, and you see that through the liver you see this more echogenic material, and inside you see the heart beating, but it is basically in a box, in a coat of fibers. Another case. This is a case a patient who I saw in Germany, that was he was a prisoner at the local prison, and he was from Angola originally, and apparently he had a pericarditis in Angola, and the prison people were quite afraid because he had TB pericarditis, but it was obviously all treated and all old, and he knew this. What you can see in the ultrasound is here this denting of the left, in this case the left ventricle, and this calcifications, this echogenic material which even throws shadows. And because in Germany we have all the means and we have all the possibilities, so we did a CT scan for him, and you can see this surrounding the heart. There is this calcification which is actually almost ring-like, and the radiographers, they did a 3D reconstruction, and you can see how the white here is the spine, and obviously here that is the almost bone-like ring around the heart, and that of course is a form of constrictive healing of pericarditis. This patient was basically asymptomatic. He only complained about mild swollen feet in the evening, and he was definitely not willing or happy to be operated, and it would be completely useless. So this is something which you can treat, or I mean, in this case we didn't even need to treat anything. It is just like a scar from a previous TB pericarditis. So let's go back to the clinic, and we see another patient, 24-year-old female, HIV positive patients with increasing shortness of breath 1 month after delivery. The chest X-ray looks actually very much the same, and we will now look with the ultrasound, and we look at this heart again just for our orientation. In front here, the liver, right ventricle, right atrium, left ventricle. So the first question we answered was, is there pericardial effusion? Well, there is a tiny little bit of pericardial effusion up here, but that is not really the problem in this case. The next question would be, is the left ventricle pumping? And have a look at this. Is the left ventricle, is it concentrically moving inward? Is the wall thickening, or is it just not doing that? What do you think? Look at it for a while, and I think we can all agree that this left ventricle is not pumping well. It is actually pumping terribly bad. It is basically not contracting at all, and hardly pumping. So this is, of course, the root cause of the problem here, which is the left ventricular failure, which is cardiomyopathy. Cardiomyopathy in an African patient can have multiple causes. Their common thing is infections and post-infectious post-myocarditis. HIV infection can cause a cardiomyopathy, particularly when the CD4 count goes very low. There are other reasons. Of course, alcohol intake might be a reason. Excessive alcohol intake, which would be a toxic cardiomyopathy. Chemotherapy can be a cause when cardiotoxic drugs are given, but also other nutrition, iron overload in some areas, and genetic factors. And one thing maybe to mention is, and this is of course important for her, is postpartum cardiomyopathy. So in this case, 1 month after delivery, this is highly likely to be due to the pregnancy and being postpartum cardiomyopathy. But the sonographic image does not differ between all these etiologies. So it is mainly an enlarged left ventricle with a wall that is not moving inward, with a wall that is not thickening. And that is the hallmark of cardiomyopathy. Obviously, when the left heart is not pumping, eventually the right heart will also dilate, and that you can see here as well that the right atrium is relatively large. So this is, of course, a consequence of the failing of the left heart. Let's have a look at the next patient. In this case, again, our 24-year-old female HIV positive patient with increasing shortness of breath 1 month after delivery. But additionally, she also has a swollen leg, a unilaterally swollen leg, which of course makes us think about DVT, which is associated, which can be associated with pregnancy, and the heart looks similar. Let's have a look at the ultrasound in this case. This is the ultrasound of the heart. So let's go through our questions again. The question number 1 was, is there a pericardial effusion? And definitely yes, there is a little bit of pericardial effusion. Not very, very big, but there is a pericardial effusion. Question number 2 was, is the left ventricle pumping? And now nicely in comparison to the one we saw before, this left ventricle is pumping quite well. The third question is, how do the left ventricle and the right ventricle compare? And usually, as you are aware from your anatomy books, the left ventricle should be twice the size of the right ventricle. How is that here? Well, definitely not the case. The left ventricle is significantly smaller than the right. So this is simply a case of cor pulmonale, and of the reason of that is to be determined. So cor pulmonale can have multiple reasons. Can be a pre-existing lung disease, long-standing tuberculosis, for example, can destroy the lungs and then by that reduce the vascular bed. Recurrent thromboembolism, that's what our case here should suggest, can cause cor pulmonale vascular, and then there are other reasons like primary arterial pulmonary hypertension, and compression, like lymph nodes compressing on or tumors compressing on the vasculature. But that has to be determined. But what is definitely the case is that we have an increased right heart workload. We have increased pulmonary pressure, and what you can see when you look at the free wall of the right ventricle, you can see that it is quite muscular. It's quite thick. It's very trabecular. It's not as compact as the left ventricle wall, but it is still. You can see these trabecular muscles more prominent than you usually see them. So this muscular hypertrophy, of course, needs time to develop. So that is a sign of that it is a longer standing process, because the heart had time to adapt to the higher workload. Again, back to another patient. Again, this 24-year-old female HIV positive patient with increasing shortness of breath, and for a change, the X-ray has changed a little bit. As you can see, it is, compared to the previous one, there is a little bit more of a standing egg configuration. It looks slightly different, but to determine what is behind it, the X-ray can help, and I think some of you might have already an idea what we are looking at, especially as the left main bronchus is quite elevated. But it is much easier to appreciate the underlying problem when we look at the ultrasound. This is her ultrasound. What do we see? Let's go through our curls question. Is there a pericardial effusion? Well, there might be a little bit here, but it is hardly worth mentioning. How is the left ventricle pumping? It is slow, but it is pumping reasonably well. There is contraction and concentric getting smaller of the left ventricle. How do left and right side compare? In this view, it seems that the right is slightly a little bit bigger, but it is almost the same, so it is not as marked as it is was in the example before. And the next question would be, how do left ventricle and left atrium compare? And obviously, normally the left ventricle should be the larger. It's the main chamber, so it should be the larger structure. But how is that in this case? The opposite. So the left atrium is significantly bigger than the left ventricle. And why is that? Well, if it is again a question of pressure building up and dilating it, and you can already guess that here this is the mitral valve between the two cardiac chambers, and that is thickened and that is stenotic. And when it is nicely visible, you see that it is round and dooming almost. So that is the underlying problem here. There is a mitral valve stenosis. And in our setting, most of the valvular problems in the heart are not due to degenerative valvular disease like they are in Europe or in the US, but they are mostly problems of infections, either of endocarditis directly, or as in this case and more commonly as a post-infectious complication, the post-rheumatic heart disease. And that is what we are looking here at. So basically, by comparing the left atrium with the left ventricle, we get an idea that there must be some problem with the inflow of blood from the left atrium to the left ventricle, and that is a hallmark of mitral valve disease. And mitral valve disease is most commonly caused by rheumatic heart disease. So that's what we are looking at here in our question number 4. Here is another example. Again, a different patient with we see the right heart on this side, the left heart on this side with the left ventricle, and the larger and roundish and blown up balloon of a left atrium. And again, as we look at the mitral valve, there are structures, there are appendices, it seems thickened, it seems just more prominent, and it seems not to open properly. So that is not what I want you to look at. I want you mainly to look at the fact that this is larger than this. So there must be a reason, and the main reason is the stenosis in between. Last case. This is again same chest X-ray. This is a 44-year-old female patient with increasing shortness of breath on ART, and we see there is the same chest X-ray configuration. And what do we find in the ultrasound? Again, something different. Let's go through all our questions. Is there a pericardial effusion? Yes, there is a tiny pericardial effusion, but certainly not the problem. Is the left ventricle pumping? Well, it is not particularly well pumping. It is pumping a little bit, but not very well. How do left ventricle and right ventricle compare? Reasonably okay. The left ventricle seems to be bigger than the right. How do left ventricle and left atrium compare? They are okay. Left ventricle is bigger than left atrium. But then how is the thickness of the left ventricular wall? And the best way to measure that is actually, if you want to measure it, then you measure usually the septum. But in this case, it is even a little bit more pronounced on this side. You see that the wall is very, very thick. So this is this between the two white lines is 1 centimeter. So this is certainly around 2-3 centimeters, and here it's also it is thicker than a centimeter and a half. Usually the septum here at that area, you measure it at the end of the diastole. So when the chamber is largest, then you measure it, and it should not be thicker than 12 millimeter. I mean, I wouldn't give 13 might be okay or not. It's not about a millimeter, but it is, if it is significantly more than 11, 12, then let's say 13, 14, it is a good sign of left ventricular hypertrophy. And of course, this hypertrophy can secondarily lead to problems like cardiac failure, like probably happened in this case. And if we find that, we of course need to think about what can be the root cause of that. And of course, the main cause for left ventricular hypertrophy in our setting is hypertension, undiagnosed hypertension, untreated hypertension, not sufficiently treated hypertension, you name it. And that is something which of course we can then as well treat. When you find a heart like that is really thick and muscular, my first next step, because I'm already have the ultrasound machine there, is to have a quick look at the kidneys, and we will deal with the kidneys in another lecture. But very often in these cases you see small and shrunken echogenic kidneys, which can be pointing you towards that this is a case of secondary renal kidney-induced hypertension, or the other way around, that these kidneys are already severely damaged by the long-standing hypertension. So definitely in any case, it would be good to have an ultrasound of the kidneys and to have a creatinine and a renal function tests to see where this is going. Good, and with this we are at the end of the curls, the curly curls. And this is a little, you can't see that very well, but you get that table in your in the app as well. You can see that from this enlarged, radiologically enlarged heart, the ultrasound helped us to get a differential diagnosis on to get much more closer what is the underlying cardiac condition. Is it, question number 1, a pericardial effusion, pericarditis? Do we need to treat TB? Is, question number 2, the left heart not pumping? Do we need to start diuretics, spironolactone ACE inhibitors, and that lot? Do we have question 3, the right heart bigger than the left? In this case, we need to deal with pulmonary hypertension. We need to see that is there a thrombosis, which can be the underlying cause? Is there a pulmonary disease which we can treat, or do we need to treat the symptoms? Do we know the pressure with a calcium channel blocker? Or is the left atrium bigger than the left ventricle, pointing to much rheumatoid heart disease? Or, as we saw at the end, is the left ventricle very muscular, and is it a case of hypertrophic heart disease? And with this, I think we are at the end. Thank you.